All right, guys, welcome back to Underground Science. In this video, we'll be talking about alpha thalassemia. Okay, so in the next two videos, right, we'll be talking about alpha thalassemia and beta thalassemia. Okay, and then after that, we will have covered the main types of microcytic anemias. Okay, so we've already talked about sideroblastic anemia, iron deficiency anemia, and anemia of chronic disease. Okay, so now we have the last type of microcytic anemia, which is thalassemia. In this video, we'll focus on alpha thalassemia. Okay, so let's go and get started. So if we just talk about the basics, right? Alpha thalassemia, right? You have a deletion of your alpha, one of your alpha globin chains, or two, or three, or four, right? So that would be alpha thalassemia. When we talk about beta thalassemia in the next video, we'll find out there that due to a mutation, right, that leads to decreased beta globin chains. Okay, so then if you have decreased beta globin chains due to a mutation, for example, that can lead to beta thalassemia. Okay, and um, it's important to remember what makes up hemoglobin, right? So hemoglobin is made up of heme and globin, right? If you reduce your globin, then that means you reduce the total hemoglobin, right? And if you reduce the amount of hemoglobin in your red blood cells will be smaller than usual, which means thalassemia would be a microcytic anemia, where your MCV or your mean corpuscular volume would be less than 80 femtoliters. All right, so I hope this part makes sense. So before we start talking about alpha thalassemia and thalassemia in general, we should understand the different types of hemoglobin. Okay, so we have different types of hemoglobin. All right, so right here. So the first type, the main type, right, is adult hemoglobin. All right, so that's identified as hemoglobin A, right? That's written as hemoglobin A or adult hemoglobin. This is about 95 to 98%. This makes up 95 to 98% of our hemoglobin, right? Since adult hemoglobin is made up of two alpha globin chains and two beta globin chains. All right. So that's adult hemoglobin. Then we have another type of hemoglobin, right? It's another type of adult hemoglobin, but only makes up around 2 to 3% of our hemoglobin. Okay, it's called hemoglobin A2. Okay, and it's made up of two alpha chains and two delta chains. Okay. And then our last type of hemoglobin to discuss is fetal hemoglobin. All right. Fetal hemoglobin is made up of two alpha chains and two gamma chains. All right. So it's important to keep these in mind because it'll come into play when we talk about alpha thalassemia and beta thalassemia. Okay. So the basic pathophysiology, as we mentioned, right, of thalassemia is decreased or absent globin chain production, which means that you can't produce adequate hemoglobin, right? Which means you won't be able to produce proper functioning red blood cells, right? So that means you're going to have ineffective erythropoiesis or the ineffective production of red blood cells, and you're going to have hemolysis. And we'll see how that happens, right? Especially in alpha thalassemia, which we'll talk about in this video. All right, so you get hemolysis and ineffective erythropoiesis in thalassemia. Okay, so let's go ahead and talk about alpha thalassemia now, which is going to be what we talk about in this video. So alpha thalassemia, right? We have four alpha globin chain genes. Okay, we have four alpha chain genes. Okay, so we're going to label this as this chromosome is from mom and this chromosome is from dad. Now, each chromosome, and this is going to be chromosome 16, okay, because that's where you find your alpha chain genes. Okay, this is where you're going to find your alpha globin chain genes. So we're going to label this as the alpha 1 gene and alpha 2 gene. Okay, they're both going to code for the alpha globin chain. All right. And then from the dad's chromosome, same thing, alpha 1, alpha 2. All right, so that means that as we saw here, we have four alpha globin chain genes. Okay, so if we have four genes that code for the alpha globin chain. All right, that's important to know because that's the types, there's many different types of alpha thalassemia, and and each type, right, will be due to a deletion in one, two, or three, or all four alpha globin chains. Okay, so that's it's important to know that there's four alpha globin chains, or there's four genes that code for our alpha globin chains. All right, and now let's go see the different types. So if we have one gene deletion, okay, then that's just normal, right? You don't have any symptoms. It's asymptomatic. Okay, so the one gene deletion is just you're just a silent carrier, basically. All right. And actually, before we actually start going into it, we'll denote the genotypes, right, as like this. So we'll have alpha, alpha, right? And then we'll draw a slash. This slash is basically saying, okay, now we're moving on to the other chromosome, and then alpha, alpha, right? Because we have four alpha genes, right? So this this signifies basically this. So if you have your alpha here and alpha here from the mom's chromosome, right? That's going to be this part of this genotype notation, right? So this is signifying both alpha genes on one chromosome. Then this slash right here is signifying a separate chromosome. Okay, so that's the genotype notation we'll use. So this is going to be the chromosome from dad, where you'll have alpha and alpha. Okay, so it's going to be this. All right, so that's the genotype notation we'll use to make more sense of these different types of alpha thalassemias. So if we use this genotype, right, then what we can say is we have a deletion, right? So let's say this is, you know what, let's make a different color. So let's say we're going to say this left one is the chromosome from mom, and then the right one is going to be, what color should we make it? Let's do red. The right one is the chromosome from dad, okay? So first type of um, alpha thalassemia is going to be called the silent carrier. All right. So we're gonna write this notation, and then it'll make more sense. So we're representing the mom's chromosome with orange. So I'll write it like this, okay, like that, and then slash. So now we're talking about the dad's chromosome, which we'll do in red because that's what we said we'll represent the dad chromosomes with, right? And that will be normal. Okay, so that's the example we have here. So there's only one gene, right? Let's use a neutral color. There's only one gene that's deleted here, one alpha gene that's deleted. So this is the silent carrier type for alpha thalassemia. Okay, this is the silent carrier type. And then, of course, this will be asymptomatic because you still have three functional alpha genes, right? Three functional genes to code for the alpha globin chain. So you still have sufficient amount of alpha globin chain production. That's why this is silent. This is called the silent carrier form of alpha thalassemia. It's asymptomatic. All right. Let's move on to the next type now. The next type is called alpha thalassemia trait. All right. So again, we'll say this is the chromosome from mom, represented in orange, and in red, this is the chromosome from dad, right? So just looking at this, right, this will be represented. Let's write the genotype notation, okay? So let's pick orange, right? So for mom, we see that we have both alpha chains knocked out, right? Both are deleted. Then we draw the slash to say that, okay, we're talking about another chromosome now. And then for dad, both alpha chains are intact, right? So that's our genotype notation. So what this we said this was the alpha thalassemia trait, right? Where two genes are deleted, two alpha genes are deleted. Now, this can be either on one chromosome, like we see here. Let's actually draw it again or let's just point it out. This can be so the both alpha chains can be both alpha gene, right? Alpha gene deletions can be on one chromosome, right? Or it can be on separate chromosomes. So you can have one alpha chain deleted from mom's chromosome and one alpha gene deleted from mom's chromosome and one alpha gene deleted from dad's chromosome, which we have here. Okay, so if we represented this with our genotype notation that we've been using, so again, orange is for mom, red is for dad, right? So we would have something like this, where we have one alpha gene deleted on each chromosome. All right, so it look like that. Now, you can see here that one type of alpha thalassemia trait, right? We see both alpha genes deleted on one chromosome, right? So that would be cis, right? It's on the same chromosome. That's what cis means. And it's more common, it's more commonly seen in Asia. So that's important to remember. Cis deletions, right, where both alpha genes are deleted off the same chromosome, is more commonly seen in Asia and has a higher risk of disease in offspring. And we'll see why in a minute. Okay. Then the other type of alpha thalassemia trait is trans, where one alpha gene is deleted from one chromosome and another alpha gene is deleted from our other chromosome. Okay, and the trans deletion is more commonly seen in Africa. Okay, so what would we find here? So you would see a mild decrease, right, in your MCV, your mean corpuscular volume. All right, so mild decrease, and you may see mild anemia too. All right, but obviously it's not going to be as bad as our other types, which we'll see in a moment. But we said that we would talk about why the cis deletion is worse for offspring, right? So let's see why it's worse. And if we just draw a quick diagram, right, we can see why it's worse. So let's imagine, right, if we just go to the side here. So we'll be using our genotype notations. Okay, that's what we've been drawing up. So we represented orange for mom, right? So we'll just write it here. This orange will be for mom, red will be for dad. All right. And we said what? Cis deletions are more dangerous because you have more chance of passing, right, that to the offspring. All right. So you have a higher risk of disease in offspring. All right. So let's make an example right here. Okay. So let's say we have a person, right? And the chromosome they got from mom or dad, doesn't matter. We're just trying to say an example, right? So let's say that um, the chromosome from mom, right, for this person has the cis deletion, and then the chromosome for dad, right, is normal. So we have normal alpha chains, right? Alpha genes. So that's going to be for this person, right? And then let's say the person they mate with or have offspring with has a cis deletion too, right? So that way we can see why cis deletions are worse for the offspring. Okay, so the person they mate with is going to also have, and let's say that one, right? It doesn't matter which, but we can just say that they're going to have their dad's chromosome, right, is going to be having that cis deletion, and let's say the chromosome they got from their mom has two normal alpha genes. So we're gonna have like that, right? So if these two people mate, what will we get? So let's see. So if you just say, all right, right here, right, is your one chromosome, and then like that, right? And then we're gonna have like that, right? So if these two people mate, right, what will we get? So now let's see why cis deletions are worse for the offspring. Okay, so we're gonna have these combinations. Okay, so we're gonna have what this is gonna be. So this offspring, right, will have two alpha gene deletions on one chromosome, and then normal normal two normal alpha genes on their other chromosome. Okay, then this offspring will have two normal alpha genes, and then um, two normal alpha genes, right? So from both parents. But then what about this offspring, right? So let's see this offspring. This offspring will have two alpha gene deletions on one chromosome and two alpha gene deletions on the other chromosome. And then we can just draw this for this, right? So look at this offspring right here, right? So that's why cis deletions are bad, because if you have a cis deletion and then you mate with another person that has a cis deletion, you have a 25% chance of having a fatal result, right? This is called hydrops fetalis, and we'll talk about that in a moment because that's the last type of alpha thalassemia we'll discuss, right? And this is lethal. Okay, it's lethal in utero, right? So it's lethal in utero. Okay, but as compared to if you compare a trans, right, a trans deletion, right, where you're gonna have something like this, a trans deletion where you're gonna have like that from the mother, right? And then let's say we have the same for the father, mates with another person that has a trans deletion. So same thing, right? And then if we drew the Punnett square out for that, you would have something like this. Your you're gonna have a normal, this is gonna be a trans deletion, right? This offspring will have a trans deletion, then this offspring will have a trans deletion, right? Everyone's gonna have a trans deletion basically. So, right, and I mean, we don't have to say the normal colors now because we can see that everyone will have a trans deletion, right? So it'll save some time. But you can see like, okay, everyone has a trans deletion, so everyone has the alpha thalassemia trait here, right? All the offspring will have alpha thalassemia trait, but no one's going to have a fatal hydrops fatalis though, right? So that's why a cis deletion is more dangerous for the offspring, all right? So my apologies, right? That took a little longer than usual, but hopefully that made sense, right? Why cis deletions are worse. Remember, cis deletions are more common in Asia, trans deletions are more common in Africa. Let's move on to the third type of alpha thalassemia, which is three gene deletions. Okay, so if we again said that this was the mom's chromosome in orange, and this was the dad's chromosome in red, right? And we drew the genotype notation for that, we would see, okay, both alpha genes deleted for mom, and then one alpha gene deleted for dad, right? So then that'd be like that and like that, okay? So three genes deleted though, right? This is severe now, okay? And the reason why is if you have three out of the four alpha genes that are deleted, one alpha gene is not enough to produce adequate alpha globin chains, all right? So if you don't produce adequate alpha globin chains, your hemoglobin, your the amount of hemoglobin produced drops. Okay, so that's where you get severe anemia, right? Severe anemia. So that's one of the findings. Now, here's the thing, right? Remember, alpha thalassemia, right? If you delete all three chains, you don't produce enough alpha globin chains anymore. If you delete all three alpha globin genes, because you only have one alpha globin gene left that's functional, that's not enough, okay, to produce enough alpha globin chains. So if we looked at what was adult hemoglobin again? Remember, we said this would come into play again. Adult hemoglobin was two alpha chains and two beta chains, right? Well, if you delete, if you're not producing adequate alpha chains anymore, and you only have beta chains, these beta chains will start combining with other beta chains, and you will start getting beta tetramers, okay? Beta 4 tetramers, basically. So you can write this as this too, okay? And that's horrible. Why? Because these beta tetramers, right? These beta chain tetramers can precipitate, okay, can precipitate and cause red blood cell destruction. So precipitate inside the red blood cells and cause red blood cell destruction, or also called hemolysis, okay? That's going to be bad because now you're destroying your red blood cells. And on top of that, you're not making enough hemoglobin, right? Because you're not making enough alpha globin chains. So you have severe anemia and destruction of your red blood cells. All right. So that's horrible. It's not good. So and then what is this called? Your beta tetramers? That's called hemoglobin H. Okay, that's important to remember. All right. So hemoglobin H are the beta tetramers that you form in your alpha thalassemia type where you have three gene deletions. Okay. So what is that called? All right, so we said beta tetramers are called hemoglobin H, right? So the alpha thalassemia type where you have three gene deletions, that's called hemoglobin H disease. All right, so it's the third type. Now let's move on to the fourth type of alpha thalassemia, which is all four alpha genes are deleted. So this is the worst type, right? So you're gonna have something like this where both alpha chains on each chromosome is deleted. Okay, so this should be in red. Right? You're gonna have something like that. So you have no functional alpha genes. which means you're producing no alpha globin chains. So again, you'll have, but this is actually lethal, okay? Because if you look at hemoglobin F, right, what was fetal hemoglobin made up of, right? Fetal hemoglobin was made up of 2 alpha and 2 gamma, right? 2 alpha and 2 gamma. Now, we just said in this subtype, all 4 alpha genes are deleted, so you're producing no alpha globin chains. So that means the gamma chains will start combining with other gamma chains, and you're going to form gamma tetramers. Now, gamma tetramers is called hemoglobin BARTs, all right? So you're going to start forming gamma tetramers, and that's called hemoglobin BARTs. And this leads to intrauterine death, right? Because gamma tetramers, right, what they do is they actually have a much higher affinity for oxygen than normal hemoglobin, right? So they're not going to let go of the oxygen, so your tissues won't get any oxygen, right? Because normal hemoglobin is supposed to carry that oxygen to your tissues and deliver it. Gamma tetramers, they love this oxygen. They're not going to let it go. Okay, so your tissues won't get any oxygen, so it's lethal in utero. Okay, so you get intrauterine death and edema and whatnot. So another name for this subtype of thalassemia, right, or alpha thalassemia, where you have 4 alpha gene deletions, is called hydrops fetalis. Okay, and of course, because you form gamma tetramers, again, this can cause red blood cell destruction. So you see hemolysis in this subtype also. All right. So those are the 4 main types of alpha thalassemia. Okay. So let's see what we have next. So let's talk about hemoglobin H disease, which is when you have 3 alpha gene deletions. And let's talk about the findings. Because remember, alpha thalassemia trait is, you have mild decrease in mean corpuscular volume and mild anemia. So the main types of alpha thalassemia that we actually need to discuss, right, because the severity is high, is hemoglobin H disease, which is 3 alpha gene deletions, and hydroxyphthalus, which is 4. Okay, alpha gene deletions. So hemoglobin H disease, 3 alpha gene deletions. Okay. So here, of course, you would see severe anemia. Okay, well, let's talk about this, right, for a moment here. So again, in hemoglobin H disease, you have 3 alpha genes deleted. Okay, if you have 3 alpha globin genes deleted, right, you normally have 4, right? So one functional alpha globin gene is not enough to form adequate amount of alpha globin chains. Okay, so you get a severe alpha globin chain deficiency. And remember, we said hemoglobin is made up of hemoglobin, right? If you have severe deficiency in an alpha globin chain production, you're not producing enough globin. And without enough globin, you're not producing enough hemoglobin. And then that's going to lead to severe anemia, okay? And remember, if we talk about the different types of hemoglobin, right? Hemoglobin A is what? 2 alpha and 2 beta, right? Hemoglobin A2 is made up of alpha and delta, right? Right? Alpha and delta. And then hemoglobin F is made up of alpha and gamma. So all types of hemoglobin have alpha globin chains in it. So if you have hemoglobin H disease where you only have one functional alpha globin gene, then you won't be able to make so you won't have normal amounts of any of these types of hemoglobin, right? Because all these types of hemoglobin need alpha globin chains. But if we look at the adult type, right, the main type, then if you have severe deficiency in alpha globin chain production, you have now all the extra beta globin chains start binding together and form beta tetramers, as we talked about, right? So you can get beta tetramers. Why is that bad? Well, if you have beta tetramers, right, that can precipitate and destroy red blood cells. Okay, but first let's just talk about one step at a time. So you have low alpha globin chains, which means you don't make adequate hemoglobin. Okay, if you don't make adequate hemoglobin, well, what does hemoglobin do? It delivers oxygen to your tissues. You don't have adequate hemoglobin, you get hypoxia, low delivery of oxygen to your tissues. All right, and we'll talk about this soon. But remember, So if you get hypoxia, right, because of ineffective delivery of oxygen, right, because you don't have normal hemoglobin, one of those tissues, right, that can sense hypoxia are your kidneys. So what does your kidneys do? What do your kidneys do in response to hypoxia? They secrete a lot of EPO, all right? And we'll see why that comes into play soon, all right? Actually, we can talk about it now, right? So if you're secreting a bunch of EPO, right, well, that EPO is going to go to your bone marrow and stimulate the crap out of it, right? So you're going to get massive stimulation in erythropoiesis, okay? So massive marrow expansion, all right? So that's one thing that's going to happen. Now, we said that we have beta tetramers, right? Hemoglobin H. Now, why is this bad? Because beta tetramers have a much higher affinity to oxygen than normal hemoglobin. So it won't release this oxygen to your tissues. That's going to also contribute to hypoxia. Not only that, but beta tetramers inside your red blood cells are not stable. They will precipitate out and form Heinz bodies. Okay. So that's one important thing to remember. Okay. They're going to precipitate out and form Heinz bodies. Why is this bad? Because Heinz bodies damage your red blood cell membrane. Okay. So it damages your red blood cell membrane. And if you have a damaged red blood cell membrane, right, the Heinz bodies plus the damaged red blood cell membrane can go to your spleen and get destroyed. So you're destroying your red blood cells. Okay. So, and if your red blood cells get destroyed in your spleen, that's extravascular hemolysis, right? Because it's happening outside your blood vessels. All right. And because you have this you have dysfunctional hemoglobin, right? Abnormal hemoglobin, this not only will cause extravascular hemolysis, but your red blood cell precursor cells in your bone marrow will also be destroyed. Okay, so that's important to remember also. So now we see why that leads to severe anemia, right? And how hemolysis occurs. So these two are taken care of. Now, why do you get splenomegaly? Well, because your spleen's working overtime now to destroy all these red blood cells, right? To get rid of them because they have abnormal hemoglobin and Heinz bodies. That's damaging the red blood cell membranes. So you don't want to keep those red blood cells around. So your spleen is working extra, right, overtime to destroy these red blood cells. So your spleen gets bigger. All right. So that's important to remember. So why do you get hepatomegaly? Right? Well, if you're not able to do, remember we said what was one main finding? Ineffective erythropoiesis, right? Why can't you do effective erythropoiesis in your bone marrow? Well, it turns out, right, this abnormal hemoglobin, right, in your bone marrow. So if we draw a quick diagram, right, just to represent the fact that we're talking about bone here. Okay, so in your red bone marrow, we have red blood cell precursors, right? So we have RBC precursors. Now, remember, we don't have any alpha chains, right? So if you have abnormal hemoglobin, this leads to the destruction of these red blood cell precursors inside your red bone marrow. Okay, so that's why you have ineffective erythropoiesis. And on top of that, we said we're doing extravascular hemolysis in your spleen too, because of the Heinz bodies. So then someone has to take over, right, for hematopoiesis. So your liver does. Your liver tries to take over and do hematopoiesis. So your liver gets big too. So that's why you get hepatomegaly also, right? So that should make sense too. So what can you see things with hepatosplenomegaly, right? You can see things like abdominal fullness, right? You can see things like abdominal fullness, early satiety, okay? So those are common symptoms to see, and palpable organs, of course. And then why would you get jaundice, right, in hemoglobin H disease? Well, remember, what did we say? We get Heinz body formations because of the precipitation of the beta tetramers, right? That goes to your spleen and gets destroyed. Now, when you destroy red blood cells in your spleen, you get indirect bilirubin release, okay? Unconjugated bilirubin release gets released into your bloodstream. Now, if you have a lot of extravascular hemolysis going on, which is what we do see in this, right? you're going to get a lot of indirect bilirubin getting released into your blood, okay? And we know that high levels of bilirubin can present as can lead to jaundice, which is a yellowish hue, right, in your skin and your sclera, for example. So that's why you get jaundice because of the extravascular hemolysis. All right, and we said we get bone marrow expansion, right? Remember, we mentioned the fact that you have hypoxia, right, which stimulates your kidneys to release a lot of erythropoietin, which goes to your bone marrow, and you get massive bone marrow expansion. Okay, I mean, you get massive bone marrow hyperplasia, right? And also, your liver starts trying to do hematopoiesis also, right? Because you have excessive red blood cell destruction, and on top of that, you have red blood cell precursors that are also dying in your bone marrow because of the abnormal hemoglobin formation. So you have ineffective erythropoiesis, okay? So that's why you have hepatomegaly, which we talked about. But so you have normal bone marrow um, hyperplasia, right? But you also have bone marrow expansion, meaning other parts of your body starts trying to take over, okay? Like your bones of your skull, right? You get bone marrow expansion, which leads to things like chipmunk facies and crew cut skull on X-ray. Again, let's make this clear, okay? Why do you get we said, okay, first let's talk about the fact that we have ineffective erythropoiesis. That's really important to remember. Why do you have ineffective erythropoiesis in your normal bone marrow, right? In your long bones, for example. Why do you have ineffective erythropoiesis? You have ineffective erythropoiesis because you're not making normal hemoglobin. So your red blood cell precursors in your red bone marrow start getting destroyed, okay? Because you have abnormal hemoglobin, so they get destroyed and you're not able to make functional red blood cells, okay, as much as usual. And on top of that, again, because of the abnormal hemoglobin, right, you get Heinz bodies. So you get beta tetramers that precipitate, which are Heinz bodies that damages your red blood cell membrane, that goes to your spleen, and you get hemolysis, extravascular hemolysis, okay, which leads to jaundice, like we said, and splenomegaly. So if you're getting ineffective erythropoiesis because your bone marrow is not able to produce adequate and functional red blood cells, and you're also hemolyzing red blood cells in your spleen, then someone wants to start to take over, right? Someone needs to take over. So your liver tries to do that, which is called extramedullary hematopoiesis, right? Hematopoiesis occurring outside of your bone marrow. So that's why you get hepatomegaly or enlargement of your liver. But then you start getting massive bone marrow expansion. Why? Because beta tetramers are not functional hemoglobin. So that means you get hypoxia. If you get hypoxia, one of those tissues being your kidney, right? What does your kidneys do? What do your kidneys do in response to hypoxia? They release a ton of erythropoietin. Erythropoietin stimulates the crap out of your bone marrow, but in other places now, like the bones of your face and skull. That's why you get an overgrowth of your maxillary bone, right? Frontal bossing, and that's where you get a feature like chipmunk face sheath. And you also get crew cut skull on X-ray. Okay, that's the reason because of massive bone marrow expansion. All right, so hopefully, that connection makes sense. All right, so the last thing we need to talk about in hemoglobin H disease is the increased risk of parvovirus B19 aplastic crisis. Okay, so now what's this? So remember, you already have ineffective erythropoiesis, okay? Your red blood cell precursor cells in your bone marrow are dying. Why? You have abnormal hemoglobin. So if you already are not producing functional red blood cells, right? Because you have your red blood cell precursors are dying in your red bone marrow. And on top of that, you get a parvovirus B19 infection. Why would that be bad? Because parvovirus B19 literally turns off red blood cell production. Okay, it inhibits erythropoiesis. So parvovirus B19 is inhibiting erythropoiesis, and on top of that, you have ineffective erythropoiesis. So you can totally shut down production of your red blood cells, right? So that's why you have an increased risk of aplastic crisis. all right, when talking about hemoglobin H disease and parvovirus B19. You can totally shut off erythropoiesis, which would be horrible, right? Now, something important to remember is if you have if you have hypoxia, your kidneys release erythropoietin, right? But despite the erythropoietin release, you still have ineffective erythropoiesis. Again, why? You don't have normal hemoglobin. So your erythroblasts die, right? In your red bone marrow. Okay. But if you're not having effective erythropoiesis, what would you want to do, right? Your body's going to think, okay, well, if I'm not properly producing functional red blood cells, maybe I need more iron. So what it's going to do is, due to the high EPO, your liver will shut down hepcidin production. Okay. So if your liver shuts down hepcidin production, then that means ferroportin won't be inhibited anymore, and you're going to reabsorb a bunch of iron from your gut and into your blood. So you may see elevated iron levels in hemoglobin H disease. Okay. So that's important to remember too. That's an important relationship to remember between EPO, hepcidin, and ineffective erythropoiesis. All right. And remember, this hepatomegaly that happens is called extramedullary hematopoiesis. Okay, so there's a lot of things happening here in hemoglobin H disease. And this is actually the main subtype to talk about because the other severe subtype, hydrops fetalis, right? I mean, it's lethal in utero. So that's just the main thing to know there. So now that we have a good understanding, right, um, of of hemoglobin H disease and alpha thalassemia and what findings you can see, let's talk about the labs. All right. So in our labs, what do we see? So if we do a CBC, right? Remember, this is alpha thalassemia. You have a reduction in alpha chains. So you can expect your hemoglobin to be lower than normal, right, in your red blood cells. So you can expect your red blood cells to be microcytic. So mean corpuscular volume of less than 80 femtoliters classifies thalassemia as a microcytic anemia. All right. And you may have normal or even elevated red blood cells. Now, why would you have elevated red blood cells? Well, let's compare this to other microcytic anemias, right? Because we said this is anemia, but then we're saying we have more than normal red blood cells, right? So I thought it was the opposite. So in iron deficiency anemia, right? If we just compare this real quick, in iron deficiency anemia, you didn't have enough iron. So then you would if you don't have enough iron, right? We said again that's going to lead to lower amounts of hemoglobin production, which will lead to mild hypoxia, which will lead to erythropoietin release from your kidneys, which will go to your bone marrow and try to, make your bone marrow start to produce more red blood cells, right? Hyperplasia of your bone marrow. But the thing is, you don't have enough iron to form a lot of more red blood cells, right? So even if EPO is stimulating your bone marrow, you don't have the building blocks to make more red blood cells. So that's why you would still see a low red blood cell count. Now, if we talk about anemia of chronic disease, remember here you're producing a lot of hepcidin because you have a lot of inflammation, right? So you're storing a lot of that iron inside your cells. And so that means and like, for example, your bone marrow macrophages are storing the iron rather than giving it to your erythroblasts in order for your erythroblasts to have proper hemoglobin. So again, even though your iron you have a lot of stored iron, you're not releasing that iron, so your bone marrow is not having enough building blocks like iron, right, to make adequate amount of red blood cells. So you would have low red blood cells and anemia of chronic disease too, right? And if you looked at sideroblastic anemia, right? So sideroblastic anemia, here you have adequate iron, but you don't have enough protoporphyrin to form heme. Okay. So again, you have lower production of hemoglobin, which can lead to mild hypoxia, which your kidneys can respond to that by secreting more erythropoietin, right? In the hopes of making more red blood cells. But you don't have protoporphyrin though, right? So you can't make adequate hemoglobin, right? So, but here you still have adequate iron. So your red blood cell count may be normal or low, okay? But when we're talking about thalassemia, though, there is no problem in iron, right? You actually have probably elevated iron levels, right? Because we talked about the fact that you have low hepcidin, so you have more iron reabsorption from the gut. So So iron, it's not the problem with building blocks. You have enough building blocks to make red blood cells. So in thalassemia, right? In thalassemia, like we're talking about alpha thalassemia in this video, right? What's happening is you don't have enough hemoglobin production, right? Because you're missing alpha chains, which leads to hypoxia. Your kidneys secrete a lot of EPO, right? And that EPO acts on your bone marrow, and your bone marrow actually does produce a bunch more red blood cells. Okay, but we have to consider that those red blood cells aren't functional, right? They're small and not as functional as normal red blood cells. But your kidneys, your bone marrow does actually respond and are able to make way more red blood cells because they do have enough iron. It's not a building block issue, right? It's the issue of not having enough globin chains. Okay, so it's the bone marrow still doesn't have any problem in making a lot of red blood cells. Now, remember, we said that we do get destruction of our red blood cell precursor cells, right? Like erythroblasts, because of the fact that you have abnormal hemoglobin, so you have ineffective erythropoiesis. But a lot of those red blood cells still make it out though into your circulation, albeit they're small, right, and microcytic and non-dysfunctional, but they still make it out. So you can have elevated red blood cells, okay, because your bone marrow still responds to the elevated EPO, because your bone marrow still has enough building blocks to make red blood cells, like iron, for example, right? It has enough iron, has enough building blocks. It's not a building block issue. So that's why, especially in a milder form of alpha thalassemia, like alpha thalassemia trait, right, where you have mild anemia and mild microcytic red blood cells, right? So you have a mild decrease in hemoglobin, which triggers, again, erythropoietin release from the kidneys, and that goes to your marrow, and your marrow responds by increasing red blood cell production. Because in alpha thalassemia trait, you don't have as much ineffective erythropoiesis as you would in hemoglobin H disease and hydrops right? So we can see elevated red blood cells in thalassemia, especially the alpha thalassemia trait. All right. So and then now if we do a blood smear, something important to keep in mind is you can see target cells. Okay, so that's really important. Okay, target cells, attribute that to thalassemia. All right. Now, if you do hemoglobin electrophoresis, okay, hemoglobin electrophoresis would show hemoglobin H in hemoglobin H disease, right? So if you did a hemoglobin electrophoresis and you had hemoglobin H disease where you had three alpha gene deletions, right, you would see hemoglobin H. If one had hydrops and you did hemoglobin electrophoresis, you would see hemoglobin Barts, right, which are gamma tetramers. Okay, so those are two main findings to know in hemoglobin electrophoresis. Now, in alpha thalassemia, it's important to remember you're going to have normal hemoglobin A2, okay? And but this is not seen in beta thalassemia, which we'll talk about in the next video, where you have increased levels of hemoglobin A2 as a compensation mechanism. Because remember, hemoglobin A2 is made up of alpha chains and delta chains, okay? So, and remember, this is a type of adult hemoglobin. So if someone has alpha thalassemia, they're not producing enough alpha chains, right? But if they're not producing enough alpha chains, then there's not enough alpha chains to combine with delta chains to form hemoglobin A2, right? So you're not going to have elevated hemoglobin A2 in alpha thalassemia. But if you looked at beta thalassemia for a moment, right? Remember, normal hemoglobin A is alpha and beta, and hemoglobin A2 is alpha and delta. In beta thalassemia, if you're reducing the number of beta globin chains, then the extra alpha chains now can combine with the delta chains in order to compensate, right? And so you form more hemoglobin A2. So that's what we see in beta thalassemia, but you see normal hemoglobin A2 in alpha thalassemia, all right? And if we talk about iron studies, right? In in alpha thalassemia, it's usually normal because it's not there's no problem with iron, right? In fact, you may see elevated iron due to the decreased hepcidin levels, right? So iron studies are usually normal, right? And then remember target cells, okay? Because remember, normally, right, your red blood cells look something like that. But remember, if you have beta tetramers, right, that precipitate as Heinz bodies and destroy your membrane, right? Then you can get target cells, okay, because of the membrane instability. All right. So remember, target cells for thalassemia. Okay. And that's basically it. All right. So that's the main things to understand about alpha thalassemia. Okay, those are the main labs. Just know, okay, iron labs are normal, right? RBC count can be elevated because your marrow is trying to compensate, right? And if we talked about, so normally, right, if we talked about MCV, what is that? Low, right? So that's microcytic. What if we talk about the mean corpuscular hemoglobin concentration? Low, right? Because you're not producing enough alpha globin chains. Red cell distribution width, probably normal, right? Probably normal as compared to like iron deficiency anemia where RDW is elevated. RBC count, right? Maybe normal or elevated because why? A lot of EPO goes to your bone marrow and your bone marrow has enough building blocks to increase red blood cell production. So you may see an increased reticulocyte count also, right? Because again, remember, you're producing a lot of EPO. So your marrow responds to that, your bone marrow responds to that. On top of that, you're doing a lot of extravascular hemolysis. So again, your marrow is going to respond to that also and try to secrete more reticulocytes and red blood cells. Now, in something severe like hemoglobin H disease, you do get a lot of destruction of your erythroblasts in your bone marrow, which causes ineffective erythropoiesis, which leads to a decrease in hepcidin, right? First of all, it leads to an increase in EPO and a decrease in hepcidin, which causes bone marrow expansion. So remember, don't forget crew cut, skull, and chipmunk facies, right? So those are just the main things to always keep in mind when talking about thalassemia, right? There's a lot of stuff going on here, but as long as you can keep in mind the main labs, right? The main blood smear findings like target cells, hemoglobin electrophoresis findings, iron studies are usually normal or elevated, and you just keep that in mind. And also keep in mind about, remember when we said jaundice, right? That indirect bilirubin can make it to your urine and cause dark urine, right? As we know from our previous videos when talking about jaundice. Okay, and then of course remember that you get Heinz bodies because of the beta tetramers. And if you get a parvovirus B19, that increases your risk of aplastic crisis because parvovirus B19 inhibits erythropoiesis. Okay, so you don't want that in this because you already have ineffective erythropoiesis in alpha thalassemia, right? So you don't want to inhibit that even more with parvovirus B19. Okay, and that's basically it. Okay, that's alpha thalassemia. I know this video is probably way too long and confusing, but I just wanted to, sometimes we were beating a dead horse, but yeah, I just want to try to get it in our minds because it's important to keep all these findings, right, for thalassemia when talking about diagnosis and labs. Okay. So, so that's it for this video. Thank you guys for watching and see you guys in my future videos.